Okay. I just want to thank everyone for joining us today for this webinar. This is one in a series that the Patient-Centered Primary Care Home Program is doing in anticipation of our revised standards that will be implemented in January of 2025. So today we're going to be reviewing Standard 3E, which is preventative service reminders. And I will turn it over to my colleagues to tell you all about that standard.
Great, thanks, Amy. Well, good afternoon, everyone. My name's Becky Velasco, and I'm a verification specialist with the Patient-Centered Primary Care Home Program.
Hi, everyone. I'm Alicia Tavares, also a verification specialist with the program.
Thanks for joining us today for our webinar on PCPCH Standard 3E. First, just a few webinar logistics and Zoom etiquette reminders. This webinar will be recorded and uploaded to the PCPCH program website. If you're having any technical difficulties, please private message Amy Harris for help. If you feel comfortable, please have your camera on and put your name and organization info up. And any questions or comments you have can be put in the chat, and we will answer them during the question and answer session at the end of the presentation. Here's the agenda for today's webinar. I'm going to start by providing a brief overview of the 2025 PCPCH recognition criteria. Next, we'll deep dive into PCPCH Standard 3E, Preventive Service Reminders. Next, we will share additional PCPCH resources and upcoming learning collaboratives. Last, we'll have some time to take your questions. The Patient-Centered Primary Care Home Program was established in 2009 by the Oregon Legislature as part of the state's broader health system transformation strategy to improve access to care, reduce costs for patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support OHA's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practices build their capacity and processes to address inequities in their patient population. All practices applying or reapplying for PCPCH recognition after January 1st, 2025 must meet these new standards. And for more information, I would encourage you to watch the recording of the 2025 PCPCH Standards Overview webinar, which is on our website.
Today, I'm going to review PCPCH Standard 3E. PCPCH Standard 3E is in Core Attribute 3, which from the patient's perspective means provide or help us get the healthcare information and services we need. The intent of Standard 3E is that preventative care is a core component of primary health care. PCPCHs that proactively outreach to patients, families, and caregivers about preventive services help facilitate timely completion of recommended screenings and interventions. Practices can also work towards closing gaps in preventive care utilization by developing alternative outreach strategies for those experiencing disparities. Standard 3E is a progressive standard. This means you should select the measure within the standard that best describes your practice and will receive the points for just that measure. As you will see, the measure build on one another. You need to be meeting 3E1 to meet 3E2, and you need to be meeting 3E2 to get 3E3. There are 3 measures in Standard 3E. The first measure is 3E1. PCPCH generates lists of patients who need reminders for preventive services and ensures that they are sent appropriate reminders. This measure is worth 5 points. The second measure is 3E2. PCPCH generates lists of patients who need reminders for preventative services, ensures that they are sent appropriate reminders, and tracks the completion of those recommended preventive services. This measure is worth 10 points. The last measure in standard 3E3, PCPCH generates lists of patients who need reminders for preventive services, ensures that they are sent appropriate reminders, and tracks the completion of those recommended preventive services. PCPCH also identifies patients experiencing disparities in preventive services and develops an alternative reminder or outreach strategy. This measure is worth 15 points. This is a brand new measure in 2025 standards.
Let's go ahead and take a closer look at measure 3E1. You can go ahead and go back a slide, please. A practice is meeting measure 3E1 if it uses patient information, clinical data, and evidence-based guidelines to identify patients in need of preventive services and has a process for sending them preventive service reminders. This measure is the same as measure 2E2 in the current 2020 standards. It's being reduced in value by 5 points under the 2025 standards. Here are a couple of examples of activities that demonstrate successful implementation of measure 3E1. A practice mails a letter, postcard, or other reminders to relevant patients ages 24 to 65 years old who have not had a PEP test in the last 3 years, asking them to schedule an appointment for a well-woman exam. Another example, a practice calls every patient with a diabetes diagnosis that does not have a recorded HbA1c in the last 6 months to ask them to come in for a lab draw. It documents that those calls were made. And the last example, a practice sends a portal message to patients who are due for a colorectal cancer screening. By sending this reminder through the portal, it is automatically documented in the patient's chart. As you're completing your PCPCH application, we strongly recommend you gather and save all documentation that would be needed for a site visit. At a site visit, you would be required to show this documentation to the PCPCH program to demonstrate you are meeting the measures. For measure 3E1, you would need to provide, first, a policy, procedure, or workflow demonstrating the practice's strategy for identifying patients in need of preventive services and sending them appropriate preventive service reminders, and examples of communications with patients, families, or caregivers, reminding them of preventive services that are due.
Let's review the specifications for the second measure in the standard, measure 3E2. A practice is meeting measure 3E2 if it uses patient information, clinical data, and evidence-based guidelines to identify patients in need of preventive services. Also has a process for sending them appropriate preventive service reminders, and has a process for tracking recommended preventative services to completion. Tracking the recommended preventive services to completion is what sets this measure apart from 2E1. To meet this measure, you need to be following up on the preventive service reminders that you are sending, making sure that the patient completes the recommended service. Please note that this measure is the same as measure 2E3 in the current 2020 standards. It is being reduced in value by 5 points under the 2025 standards. Here's an example of activities that demonstrate successful implementation of measure 3E2. A practice maintains a running list of all patients who are due for a mammogram, colorectal cancer screening, and cervical cancer screening. It tracks its outreach efforts to help patients schedule an appointment and the completion of the screening. Completion of the services are documented in the chart. At a PCPCH site visit, you would need to provide the following pieces of documentation to demonstrate that you are meeting Measure 3E2. First, a policy, procedure, or workflow demonstrating practice's strategy for identifying patients in need of preventive services, sending them appropriate preventive service reminders, and ensuring that preventive services are completed. We would also want to see examples of communications with patients, families, or caregivers, reminding them of preventive services that are due.
Now let's move on to the third and final measure in Standard 3E, Measure 3E3. This is a new measure in the 2025 standards. As you will see, it takes the practice of sending preventive service reminders that we saw in Measure 3E1 and 3E2 and combines it with health equity practices. A practice is meeting Measure 3E3 if it is doing all of the following. It meets all of the specifications for Measure 3E2. It has identified a subgroup of patients experiencing at least one disparity in preventive services. And it has developed an alternative reminder or outreach strategy for this patient group. Here are a couple of examples of activities that demonstrate successful implementation of Measure 3E3. A practice runs a report of all patients who are due for a mammogram. The practice notes that patients who have identified Spanish as their primary language are not scheduling mammogram appointments at the same rate as patients who have identified English as their primary language. The practice develops mammogram reminders in Spanish and sends them to the relevant patients who have identified Spanish as their primary language. In another example, a practice runs a report on children due for a well child exam and notes that parents of children with special health care needs are not scheduling appointments at the same rate as those of other children in the practice. The practice revises its workflow so that the care coordinator is the staff member contacting these families to schedule an appointment, since the care coordinator already has an existing relationship with these families and can assist with any barriers to setting and keeping an appointment. At a PCPCH site visit, you would need to provide the following pieces of documentation to demonstrate that you are meeting Measures 3E3. First, a policy, procedure, or workflow demonstrating the practice's strategy for identifying patients in need of preventive services, sending them appropriate preventive service reminders, and ensuring that preventive services are completed, including for patients who experience disparities in preventive services. And second, examples of general communications with patients, families, or caregivers, reminding them of preventive services that are due. And finally, examples of alternative communications or outreach strategies for patients, families, and caregivers who experience disparities in a preventive service.
That includes our presentation on Standard 3E. The PCPCH program is hosting this webinar series to assist practices and other community partners in understanding the standards. Webinars are scheduled every other Friday through December. You can find a complete list of topics and registration information on our website. The next 3 webinars are listed on the slide. I hope you will join us, but webinars will be recorded and posted on our website if you can't make it. The final slide is additional resources that you may find helpful. The first is our PCPCH program website. The second is the 2025 TA Guide with detailed information about how to implement every measure and the documentation requirements. Next is a link to our TA Resources webpage. And finally, the Community Engagement Report and Evaluation. Lastly, you are always welcome to reach out to the PCPCH program with any questions through our program email.
Great. Thank you so much, Becky and Alicia, for presenting on that slide or on that standard, and also just clearly describing the changes to the existing standards, as well as the new standard or the new measure that we have in the standard for subpopulation. So now we're going to open it up to your questions or comments or any feedback that you might have. Rachel, if you wouldn't mind unsharing your screen. So you're welcome. We have a pretty small group today, so you're welcome to raise your hand and ask your question verbally if you would like, or you can put it in the chat if you feel more comfortable doing that. Also, I'll just add that if anyone has any information about how they're already implementing this standard, we'd love to hear it. I know we do know that some practices are already doing some of this work around preventative service reminders for subpopulations in their practice. If you're doing that, we'd love to hear about it. I'm sure others on the call would as well, especially for those who are just getting started. So feel free to share that too. So I'll just pause there and open it up. Oh, go ahead, Danny. Is it Danlea?
Danny-Leah.
Danny-Leah. Danny-Leah. Thank you. Go ahead, Danny-Leah.
So I do have a question. You guys are asking for what is it, like a written policy or procedure, right? In terms of for 3.E3. When you're talking about identifying like the subgroups or the subpopulations that have the disparities, is it highly recommended? Like we already have an outreach procedure for, you know, reaching out to these patients or to the general population, but not specific to those patients. Would it be okay to add a section, right? Like how we are addressing all disparities and not necessarily like Becky said, maybe patients who are primary Spanish speakers, right? Not calling out a specific one, or are you guys needing us to call out a specific subgroup and what we're doing to alleviate that?
That's a great question. So, I mean, you know, it depends on what we see at the site visit, but I would say if it's a general policy, you could probably just describe your process about how you are identifying patients that have disparities, but you wouldn't necessarily have to say like, we're identifying this particular, where, you know, we're identifying Spanish speakers, or we're identifying people based on a certain zip code, people who live in more rural areas, something like that. You wouldn't have to necessarily spell that out in your policy. But I would think that you would want to explain like what you're doing, like you're looking at your EHR data, or you're looking at this, something like that. I would defer, and then our site visitors would likely have additional questions about that, like how are you doing that exactly? And so it would be kind of a combination of like your policy, but then also what are, you know, how are you actually implementing that in practice? So that's my initial reaction, but I definitely defer to the site visit team to see if you guys feel like that would need it. I'm looking at you guys.
Yeah, yes, Amy, everything that you
Yep.
said,
Yep.
I would agree with, and yes, that would meet it, depending on what we saw at the site visit, of course.
Awesome, thank you.
Yeah, that's a good question.
Just to clarify, are we saying that basically it wouldn't have to be included in the policy, but there would need to be evidence that they did identify a subgroup and are working towards improving preventative services?
Yes.
Yes. So I guess they would have to include it in their policy, but it could be general. So it could say, we are also, I mean, however you're wording it, we are also, you know, evaluating or stratifying our patient population to identify disparities in preventive services, something like that in the policy. And they could even, you know, depending on how much detail, they could provide some detail without being too specific. Like like I said, we're looking at our EHR data, something like that. But then our site visit team would want to see that actually in action. And that's where the examples would come in.
could be helpful to have a separate policy. So once you've identified that group that is experiencing disparities, you could kind of type up maybe like a sub policy of this, because we do want to see a policy that in the documentation requirements, it says including for patients who are experiencing disparities in preventative services. So we're going to want to see that somewhere. So whether it's in a policy, whether it's, you know, in meeting minutes where you're sitting down to go over data to decide which group you're going to be working on and how you're going to be creating those workflows, it can be demonstrated in that way. But in some way, we need to see your process for how you've identified that group and what different outreach you're going to be doing for them.
Yeah, thanks for that question. Other questions folks have? Oh,
Hey, this is Randa Kusi here. Can you hear me okay?
yeah, go ahead.
So 3E3 it's a complicated standard, and as I'm listening, I'm trying to wrap my head around the whole thing. But I wonder if can we be more general in meeting the standard, going back to those patients who aren't even coming to their wellness visits in the first place and figuring out the disparities there about why they're not coming to the wellness visits, because that's where the prevention starts there. Because if they're not even getting to the wellness visits, then we can't even address the disparities in more specific things like mammograms or PAPs or colonoscopies.
So what you're asking is, could you identify your patients who are not coming in for wellness visits and do some kind of additional outreach strategy for those patients? Is that what you're asking?
Well, that's
to try
right.
to get them into the clinic.
That's right, but that would make it much more general. We wouldn't be so specific on one specific area. So let's look at the women who aren't coming in for their yearly mammograms. We'd be taking a step back to say, hey, this is a group of women that aren't even coming in for their wellness visits at all. So coming from a more general place would be the starting point to even get to this place.
Yeah, I mean, I would say that that is a disparity. I mean, certainly. I mean, it might not be a disparity that's measured by an outcome, but it is a disparity. I mean, you know, if you have, you know, most women in your population, your patient population that are coming in, and then a group that aren't, I think being able to identify those barriers and do some targeted outreach to them could potentially meet this measure. I think we'd have to talk about that as a group on our team and figure out, you know, take a closer look at the standards, review our conversations that we had with our standards advisory committee, and maybe get some additional subject matter expertise to see if that would meet the standard. So we could do that and get back to you, or and maybe put out some additional information about that. But I think that's a good question. We know that's an issue as well. Obviously, people not coming in for their annual appointments and not getting that care. We'd have to decide whether or not that kind of fits in this particular standard, though. So is that something that we could get back to you about, Randa?
Yep, that sounds great. Thank you.
Great. We will for sure. Good. Thank you for that question. It looks like we have a question in the chat here. So, okay, so it looks like Heidi says, I can't seem to raise my hand, but just want to clarify. Can our policy say that we look at patients by population, by subpopulation, for example, patients by language or age, but then our data can show which subpopulation that we're looking at? Yes, I think for your general policy, that would be fine. If you just say that you are looking at your patient by whatever subgroup. And then what you're actually presenting and sharing with the team for your documentation, or as Amber mentioned, meeting minutes or whatever, can actually show that. Yeah, that's good. And then there's a question here. Oh, it looks like Jacqueline, it's from you, but I also see you have your hand raised. So would you like to verbally ask your question, or would you like me to read it?
I'll go ahead and
Okay,
verbally
great,
ask it.
great, great.
So one of our clinics that we have, we noticed a lot of folks weren't showing up for their wellness visits. And so what we did is when we did outreach to them, we did like kind of a mini screen to ask them what the barrier to getting there was. And for a certain subpopulation, we found out that it was transportation. And so we were able to work with them to either provide a bus ticket or talk to them more extensively about how to get there, even though, you know, it's on our website and they'd been there before. But just if you identify things like that, like barriers to care that are more, yeah, would that work? Would that qualify?
That's actually that's a really good example, actually. And that's why I think we have to go back and talk about it as a team. But I think something like that, where your strategy is kind of twofold, right? So you're doing that extra piece of outreach by sending them the questionnaire, and then you're addressing that disparity or whatever that barrier might be by in like another way, with additional services, like you said, helping them with transportation. So yeah, I mean, I think that's an example that's a bit different than maybe just doing targeted outreach to them. That might maybe sending them a different type of flyer or different type of card or something like that. Doing that sort of thing where it's like twofold is a bit different, and probably something that I think our team would accept. But again, we have to take a look at that. For sure. And we could definitely provide some more guidance on that, either through the TA guide or through like an update. So we've been trying to update the TA guide as these questions come up and as we do this webinar series, because we're getting a lot of great questions like these. And so we are trying to provide some clarity around that as we go, but we're also not trying to update the TA guide every month because we know that stresses practices out when you see a new version of the TA guide. So we're trying to be careful about when we release those updates. But that's something that we can definitely provide some more guidance around for sure. So.
Yeah, because one thing we were noticing is when we did outreach, and then some of our folks that were helping were community health workers, and were asking like, why is it that you're unable to attend? And so we had kind of started marking that. And then, you see a pattern, right? Like maybe a certain clinic is like in a place that's a little harder to get to for your population, or their hours maybe aren't, quite fitting with whatever like the work is out there. And so so one of the clinics started sort of like doing this little mini screen to find out why their folks weren't able to get in. So anyway, I was just wondering, because we're doing the outreach and then you're identifying this sort of subpopulation from the outreach. So that's why, I don't know, it just came to mind.
Yeah. No, I think that's great. Thank you for sharing that too. I think that's a really great example about how, again, I think I've mentioned this before for folks who've attended these other webinars, but we do our best to write these specifications, and we rely on a lot of expertise from providers and clinicians and administrative staff at practices and our own experiences. But there's so many scenarios out there that we just aren't familiar with or don't know about, or you guys bring to us. And so really having these additional conversations and these additional questions and this additional information is really helpful, not only for us to make the technical assistance guide better, but also just for us to know kind of what else is going on out in the practices that we don't always hear about. So that's a really great example. So I appreciate you sharing that.
Oh, thank you. And I know we're a little bit different because we're so big and in such a large city. So maybe those aren't things, but I think someone put in the chat too, social determinants of health. So we were talking about, what other factors are prohibiting people from being able to attend their appointments, and sometimes they're domestic violence related. Sometimes, there are just a lot of different things that come up. So yeah. And recognizing we're a big state and there's a lot of variability.
Absolutely. Yeah, good. Thank you. Okay, let me scroll through here and make sure I'm not missing anything. It looks like Okay, so it looks like Rachel, you put a comment that says the more general activity is perhaps more relevant to 3A2, which is another standard about closing gaps in preventative service. For that. So it says, so Megan asked the question, is there a guideline on how many follow-up attempts we need to make to outreach to the patient to complete their test? And can we use social determinants of health to define your population? So yes, you can definitely use social determinants of health to define your population, absolutely. In fact, the way that you define your population who are experiencing disparities is really up to you at the practice. We don't really put any parameters around that. So you can use age, you can use location, you can use race, you can use gender identity, you can use any of the social determinants of health to identify those patients. We don't put any parameters around that at all. It's whatever makes the most sense for your patient population. And then in terms of the number of attempts, we haven't defined that in the TA guide. I mean, usually when we get these types of questions, we say things like, well, more than one, but, not so much that you're bothering them, and being a nuisance. I mean, we have a lot of discretion, or we leave a lot of the discretion up to the practice on how much. We probably would, at a site visit, our team, and you guys can correct me if I'm wrong, but we would probably look at how many times, like in the duration that you're doing it. So like, for instance, if you're only contacting a patient once in a year, that's probably not enough. So we would probably look at the duration and then the frequency combined. But we don't have any specific guide on that. If you weren't doing it like as often as we thought you should be or whatever, we would still verify the measure. We just would probably verify it with needs attention. And what that means is that, you're doing it, but next time, you probably should be doing it a little bit more often, something like that, because we don't specify the number of times that you need to be doing that outreach. So yeah, that's a good question. I'm sorry, it's a little ambiguous, but as Jacqueline mentioned, we've got, 600 practices across the state in every different type of community. And so we have to keep things a little bit ambiguous in order to, so that practices can all see themselves in the measures. So, yeah. Let's see, it looks like there's another question. Okay, can we get so Cadence asks, can we get parameters of how small of a subpopulation is too small and how large is too large? So again, that's a great question and not something we define. So if you have a really small subpopulation, but you really are working hard to get them to come in, if you notice a disparity between that subpopulation and your general population about the type of preventative services that they're receiving, and you want to target all your efforts on that subpopulation, if it's 5 people and those 5 people come in and get the preventive services that they need, that's awesome. We fully support that. And the same is true on the other side. I mean, if you, as long as you're able to demonstrate to us that there's a disparity there, the size of the subpopulation is irrelevant. And also, I would say, you can also use more than one characteristic to define a population. So for example, if you're using, if you're looking at something, let's say it's well visits, right? And you're looking at all your patients whose primary language is Spanish, and that's pretty big subpopulation. Maybe you even subcategorize that even further. So maybe you look at women who speak Spanish versus men who speak Spanish, and you maybe even, can get a little bit more refined if you find that your subpopulation feels unmanageable or too large for you. But again, it's really at the practice's discretion. So, and I would refer to my colleagues too to make sure that that sounds aligned with what you guys would want to see as well.
The only thing I might add to that is, say you have 10 Spanish speakers who are due for a preventative service and you've done outreach to them. I would hope that the practice would not be like, okay, we're done. Like, we satisfied that for PCPCH for our 2-year application, and we found this subgroup and we did different outreach and it was 10 patients and now we're done. we would hope to see at a site visit, if you started that way, that maybe you looked at a different group or a different disparity to continue that work, not just doing one kind of a one and done for a PCPCH measure, if that makes sense.
Yeah, I appreciate you saying that, Amber. I mean, we certainly would verify the measure even if you did that, because you're technically meeting the standard or you're technically meeting the measure. But again, we really, we want to make sure that practices are really, doing this work in a way that's meaningful for your practice and not just to meet the PCPCH standards, and making sure that you're really thinking through what are those disparities in your patient population, and what can you do to really improve care for those patients. So yeah, I appreciate you saying that. And that goes across the board for all of our measures. Let's see here. Follow-up question. Another one from Cadence. So disparity between the majority of our patient panel and the population, or disparity between subpopulations. I'm not sure I understand.
I can clarify. So we have a small patient panel in general, and our patient panel has high barriers related to social determinants of health. So a lot of our patients would fall into other people's subpopulations, but they're the majority of our patients. And so I'm wondering if we need to be determining this to meet the spirit of the measure, assessing disparities between subpopulations, because the majority of our patients will have the same challenges for accessing preventative care.
I see what you're saying. I think, again, this kind of goes back to, you can determine how to best address your patient population. And so for your practice, if that means comparing disparities between a subpopulation and another subpopulation, I think that that's fine. I mean, every practice is going to look different, and you might not have a good overall population to compare to. So if you're comparing a subpopulation to a subpopulation, I think that that's fine. So I would defer to our site visit team too, to just make sure that that sounds.
Yeah, I'd say if transportation is your disparity, and you might have a large population in your clinic that has that disparity, then you might do a subgroup of our Spanish speaking patients that have transportation issues, and kind of compare those two groups and see if there's a disparity with your Spanish speaking patients versus your English speaking patients.
Or, your patients that live further away from the clinic or something like that. So yeah, by zip code.
Thank you.
Yeah, of course. That's a good question too. Again, so much variation across our state.
And I was just going to add to that as well, just that oftentimes it's the process that will help us determine that. So like what your rationale is for choosing that patient population. So just as an example of something we'd want to avoid is if we visited the practice and you said, oh, like, well, we do special reminders, or we do have reminders in Spanish for Spanish speaking patients. And when we asked, like, oh, why is that? It was like, oh, because that's just what other practices do, or that's just what our organization told us to do. But you can't really speak to how they were identified, or why did you select that patient population for your practice specifically.
Yeah, also a great point. So, or even just like, oh, they were easily available to us in Spanish or something like that. Like, we would really want to be looking at that intervention being more targeted toward the patient population and what their needs are. So yeah, thanks for bringing that up as well. Okay, so let's see. Heidi has a question. Can we use the same policy workflow data from measure 2A3 for our documentation? For example, we are addressing colorectal cancer screening as a quality measure and looking at a subgroup on age. Does that documentation count for both measures? That's a great question. I would say there are differences, of course, because you're reporting data for 2A3. But if you're doing special reminders because preventative service reminders technically aren't part of 2A3. So I would say if you're doing the reminder piece, then you probably could use some of the same documentation. I would refer to the site visitors to confirm that, but I would think you could probably use some of the same as long as you're making sure that for this particular measure, you're including those preventive service reminders as well. So I don't know, I'm looking at the site visitors. I see some nods, so okay. That's a good question. And I think we're gonna find that in our in the model, there's gonna be overlap sometimes between measures. And I think when you see that, so this is just probably good general advice. So if you're looking at measures and you think, gosh, is this exactly the same? Really take a close look at those specifications. And if you have any questions, reach out to us, because it is possible that they're very similar, but it is possible too that there might be a subtle difference that maybe you're just not reading it in the same way that we're intending it, that we had intended when we wrote it. So if you see something that looks exactly the same, or you think, oh, this is identical, definitely reach out to us. And it might be identical, to be honest. But there also might be a subtle difference that we can help clarify. So definitely reach out. We're happy to.
And I just add to that 2A3 especially may involve many other standards in the model, because 2A3, it's an outcome measure. It's looking at, were you actually able to reduce disparities, and how you do that, what sorts of improvements you put in place. There's all sorts of standards in the model that provide a framework for how you could reduce those disparities. And then 2A3 is looking at, okay, like, what does the data show? Did it actually work?
Yeah, that's a great point, Rachel. Okay, let's see. Oh, good. Thank you, Cadence, for that comment. We're glad that they're helpful. We always like to get that feedback. Great. Thank you, Heidi. Good. Great. Okay, let me just go through. I don't think I missed any questions. I'm leaning in. You guys, I'm like can't see, so I'm leaning over to read the chat, and then you can't see my face. So let me just take a quick look. I don't think. Just want to make sure I didn't miss any questions in the chat. And I should put my glasses on, right? Okay, let's see. Hold. I don't see any other questions. Is there anything that hasn't been asked or that I've missed that folks want to know about this for this standard? Okay. Well, then in that case, I'll just remind, before I thank you all for coming, I'll just remind you that please feel free to reach out to our program at any time. Rachel is the one who answers our email inbox. And if she doesn't know the answer for you, she always consults the team, which isn't very often. Rachel knows a lot. But we're always happy to answer any questions you have about the standards, about the measures, about the process for applying, anything that you want to know. Feel free to always reach out to us. We're very quick. Rachel is very fast. For those of you who've emailed us before, she's very responsive. So we can get you an answer usually within a day. So definitely reach out to us if you have any questions. Or if you work with practices, I know there are some folks on this call who work for CCOs or other organizations that do practice consulting. That's awesome. We're happy to talk to you and help you and guide you, but we're also happy to answer questions from the practices that you work with. So if you ever want to involve your practice and hop on a call with us, or send us an email and loop the practice in, do that as well. We're happy to give that information not only to you as the coach, but also to the practice directly if it's helpful. Sometimes they can ask questions faster, and it's not as much of an intermediate step. So we're happy to do that as well. So, and thank you so much, everyone. Lots of kudos in there for Rachel. Of course, she's great. So thank you everyone for coming today. I hope you have a wonderful weekend. If you're in Oregon, if you live in Oregon, it's cooling off. So thank goodness for that. and I hope everyone enjoys it. Great, thank you so much.